The next part of this presentation is about the medications used to treat high blood pressure or hypertension, as well as a review of hypertension and the implications of hypertension for patients with COVID-19. The objectives of this section are for the learner to define hypertension, describe the adverse effects associated with hypertension, discuss the types of drugs used to manage hypertension, and discuss the potential adverse effects of common medications used to manage hypertension. Let us begin with, what is high blood pressure or hypertension? Unless you graduated from physical therapy school in the last couple of years, you learned a different categorization of hypertension than what is currently in use. In particular, normal is defined as a blood pressure of less than 120 millimeters of mercury systolic blood pressure and less than 80 millimeters of mercury for diastolic blood pressure. Also, there is currently no pre-hypertension, and the categorization of stage 1 hypertension dropped from a systolic blood pressure of 140 down to 130, as well as a diastolic blood pressure of 90 down to 80. These new definitions are based on a clinical practice guideline on hypertension that was published by the American Heart Association in 2017. This new definition means that nearly half of adults in the United States are now classified as having hypertension. Why this change? In part, it was due to the NIH-sponsored SPRINT trial that found that patients with hypertension who were treated more aggressively for a target blood pressure of less than 120 as opposed to just a blood pressure less than 140 were 25% less likely to develop heart failure, have a heart attack, or a stroke, or die. In other words, more aggressive treatment of blood pressure resulted in improved outcomes. Hypertension is called the silent killer because it is usually asymptomatic. Hypertension can cause headaches, but typically only if blood pressure is severely elevated. For example, over 200 millimeters of mercury at rest. It is often associated with sleep disordered breathing, such that when patients have their sleep apnea better managed, for instance with CPAP or BiPAP, that also helps to lower their blood pressure. But perhaps the most significant part is that chronic hypertension causes end organ damage. What do we mean by end organ damage? Why is it that hypertension is so detrimental? Why should it be so aggressively managed? Chronic hypertension damages blood vessels. Thus, blood flowing to other vital organs can become impaired, and those organs and tissues become damaged. These can include cardiac issues like heart failure, angina, coronary heart disease, neurologic conditions like TIAs, stroke, and dementia, as well as other conditions including retinopathy and vision loss and peripheral arterial disease. The complications associated with patients with hypertension that also develop COVID-19 are also significant. For example, a recent study of hospitalized patients in New York City, published April 22nd in the Journal of the American Medical Association, found that hypertension was the most common comorbidity of patients admitted with COVID-19. More than obesity, more than diabetes. So almost over half of the patients had hypertension. In addition, the World Health Organization, using China-based data, has published the fact that the death rate of patients with hypertension is nearly over twice as high as patients without hypertension. Patients with cardiovascular disease, the death rate is almost 3 times as high. So how should hypertension be managed? The management of a patient's blood pressure depends on how it is classified. People with a blood pressure of less than 140 systolic or less than 90 diastolic should initially be treated with non-pharmacologically, which includes diet and exercise, basically lifestyle modification, topics that physical therapists should be knowledgeable about and willing to assist patients. However, many patients will need both lifestyle modification as well as pharmacologic intervention to get to their target blood pressure levels. Here is a list of the most common classes of drugs used to treat high blood pressure in order of prescription prevalence. So we'll go through each of these classes separately. Of note, the medications listed in this presentation, as well as the subsequent presentation on medications for coronary artery disease, will have a number in parentheses that designates their ranking on the top 200 drug list. That is, the most frequently prescribed drugs in the United States as of 2017, which is the most recent set of complete data. For example, lisinopril was the number one prescribed medication in the United States in 2017. Lisinopril is an ACE inhibitor, or an angiotensin converting enzyme inhibitor, often called just an ACE-I, or more commonly an ACE inhibitor. Another medication, the combination of lisinopril along with the diuretic hydrochlorothiazide, is also in the top 50 most prescribed medications. And 3 more ACE inhibitors are in the top 200. You notice the generic name of ACE inhibitors all have the suffix pril. ACE inhibitors act via 2 important mechanisms that help lower blood pressure. First, ACE inhibitors can increase the production of nitric oxide, which is a potent vasodilator. Second, and probably the most important reason, is its action through the Renin-angiotensin-aldosterone system. So let's take a moment to discuss it. Here's an illustration of the Renin-angiotensin-aldosterone system. The angiotensin converting enzyme is located in the lungs. Thus, the lungs not only play a critical role in bringing in oxygen, getting rid of carbon dioxide, and regulating pH, but via the ACE, they also help to regulate blood pressure. Normally, ACE converts angiotensin I to angiotensin II, which mediates a variety of pathways to increase blood pressure, including the release of aldosterone, an antidiuretic hormone, and the reabsorption of sodium as well as water retention. By blocking this system, ACE inhibitors can also stop many other processes that would otherwise lead to an increase in blood pressure. Although quite effective in reducing blood pressure, like all drugs, they have adverse effects, including hypotension, or low blood pressure, which may also have weakness, dizziness, or even syncope if the blood pressure drops too low, especially in patients with impaired cardiac function. They can also decrease glomerular filtration rate, especially in patients with renal artery stenosis or patients with pre-existing renal disease. Patients can also develop hyperkalemia, or elevated potassium. As illustrated previously, by reducing aldosterone, less potassium is excreted by the kidneys, and therefore blood levels may rise. Perhaps the most common adverse effect is a dry, hacking cough, even referred to as an ACE inhibitor cough. The incidence of this is reported to be between 5 and 20%, but can be up to 50% in those with Chinese descent. Women are typically aggravated more by ACE inhibitors than men. The ACE inhibitor cough typically resolves 1 to 2 weeks after discontinuation. Angiotensin II receptor blockers, which we will discuss shortly, work via a similar mechanism in the Renin-angiotensin-aldosterone system, but they have a reduced incidence of cough. So often patients are switched from an ACE inhibitor to an angiotensin II receptor blocker. Is there a link with COVID-19 and the use of ACE inhibitors? Some early investigators hypothesized that the SARS-CoV-2 virus infects cells by attaching itself to the enzyme called ACE2. Since ACE inhibitors and angiotensin receptor blockers may raise the levels of ACE2 enzymes in the lungs, they provide a larger target for infection. However, a study published in the Journal of the American Medical Association Cardiology on April 22nd, based on data from Wuhan, China, did not find a relationship in either the severity of illness from the SARS-CoV-2 virus or death in patients taking an ACE inhibitor. Thus, patients with hypertension should not stop taking their blood pressure medications, even if it's an ACE inhibitor. The next most prescribed class of antihypertensive medications are called calcium channel blockers, also called calcium channel antagonists or calcium antagonists, sometimes abbreviated CCBs. There are two types of calcium channel blockers: dihydropyridine calcium channel blockers and non-hydropyridines. Amlodipine, the fifth most prescribed medication in the United States, and nifedipine are both DHP calcium channel blockers, whose mechanism primarily affects smooth muscle. Diltiazem, on the other hand, is a non-DHP calcium channel blocker. It's less effective at lowering blood pressure, but can also be used to manage angina and cardiac dysrhythmias. Calcium channel blockers work by blocking the entry of extracellular calcium from coming into the cell. Since intracellular calcium concentration is what strengthens the contraction of vascular smooth muscle, calcium channel blockers reduce the influx of calcium from outside the cell to inside the cell, therefore reducing vasoconstriction and promoting vasodilation or vasorelaxation. Like all antihypertensives, hypotension, especially orthostatic hypotension, is the primary adverse effect of calcium channel blockers. In addition, 20 to 30% of patients reported developing lower extremity edema, especially with the DHP calcium channel blockers. In addition, diltiazem can often decrease cardiac function. Sometimes this is intended, and other times this can be an adverse effect. Beta blockers, also known as beta antagonists, beta adrenergic blockers, come in two categories. They are selective beta blockers and non-selective beta blockers. The beta-1 receptors are primarily found on the heart. The beta-2 receptors are primarily found in the lungs. Thus, selective beta blockers primarily have their effect on the heart. The non-selective beta blockers have a more wide-ranging effect since they affect both cardiac and pulmonary system. So how do beta blockers work? To start with, let's do a little bit of a review. You may recall from physiology that the mean arterial pressure, or the MAP, is approximately equal to 1/3 the systolic blood pressure plus 2/3 the diastolic blood pressure. In addition, cardiac output, the amount of blood pumped out of the heart per minute, is the product of heart rate and stroke volume. In addition, the total peripheral resistance, or TPR, is kind of a measure of how difficult blood flow is in the peripheral circulation. So it's kind of an assessment of the arteriolar vasoactivity. We can combine these terms to get that the mean arterial pressure equals cardiac output times total peripheral resistance. Again, the mean arterial pressure equals cardiac output times total peripheral resistance. Primarily, beta blockers reduce heart rate and contractility, therefore stroke volume, and thus decrease cardiac output. If cardiac output is decreased, then that results in a decrease in mean arterial pressure, including systolic and diastolic blood pressure. Secondarily, beta blockers can reduce the sympathetic tone, which results in vasoconstriction. Therefore, as beta blockers decrease total peripheral resistance, they also decrease mean arterial pressure. Beta blockers can have a wide range of adverse effects, including, again, hypotension. But because beta blockers are blocking the sympathetic nervous system throughout the body, especially on the heart, but perhaps in other effects, beta blockers can decrease heart rate, resulting in bradycardia. They decrease contractility and stroke volume, and therefore patients with heart failure can have an exacerbation. Patients that are on a non-selective beta blocker, like propranolol, for instance, may develop bronchoconstriction due to an increase in airway resistance. This is especially prevalent in patients with pre-existing conditions such as asthma or chronic bronchitis. Because of the decrease in cardiac output and blood flow, it can also exacerbate lower extremity pain symptoms in patients with peripheral arterial disease. And lastly, because it's blocking the sympathetic system overall, some patients end up with some depression and fatigue due to beta blockers. So how do beta blockers impact exercise tolerance? So here are a couple graphs of heart rate and blood pressure response to a graded exercise test in the same individual, once before initiating beta blocker therapy and once after. Note that after initiating beta blocker therapy, there was both a blunted heart rate and blood pressure response to exercise. Hence, for any given intensity of exercise, shown as power or in watts on the x-axis, there's a lower heart rate and a lower blood pressure at each of these values. Thus, heart rate, using kind of predicted equations for heart rate and exercise intensity, don't seem to be as valid in patients on beta blockers. Instead, for patients on beta blockers, it's recommended that, especially in absence of a true maximal exercise test where you have a maximal heart rate, that perceived exertion be used to monitor intensity as opposed to heart rate. Also note that because beta blockers are reducing both heart rate and stroke volume, and therefore cardiac output, then the maximal work rate that someone is able to do ends up being reduced. Our next class of medications are angiotensin II receptor blockers, or A2RBs, or ARBs, or angiotensin receptor blockers. These medications end in the suffix sartan. Losartan, or Cozar, as the brand name is the number 9th most prescribed medication in the United States. Angiotensin receptor blockers function in a similar pathway as the ACE inhibitors, but they're one step downstream from ACE inhibitors. So they also decrease aldosterone, decrease the quantity of antidiuretic hormone, and promote vasodilation. Adverse effects are similar again. Symptomatic hypotension is a side effect that particularly seems to occur in patients on angiotensin receptor blockers, more so than ACE inhibitors. But remember, ARBs work in a similar pathway as ACE, but farther downstream. Thus, there's a less likely risk that they're going to develop the kind of ACE inhibitor cough. In fact, it's about 3 to 4 times less prevalent in patients on an ARB compared to an ACE inhibitor. And as I mentioned earlier, an ACE inhibitor cough, is one of the main reasons to switch a patient from an ACE inhibitor to an angiotensin receptor blocker. But we're going to concentrate on the thiazide and the loop diuretics, since they are the ones that are most commonly prescribed. Diuretics work by promoting diuresis, or increasing urine production, which decreases blood volume, and decreasing the amount of volume of blood in the vascular system helps to lower blood pressure. Different diuretics, as illustrated in this figure, different diuretics work in different locations within the kidney, and therefore have differing effects. The primary adverse effect of diuretics, in addition to hypotension, are electrolyte imbalances. In particular, hypokalemia, or low potassium levels, hyponatremia, low sodium levels. And these can cause a range of different symptoms. They can induce palpitations, they can induce bradycardia or tachycardia, GI symptoms such as nausea and vomiting, abdominal cramps and constipation. They can have more peripheral effects on skeletal muscle, such as weakness, cramping, fasciculations. They can develop kind of mental status changes, lethargy, confusion, agitation, headache. And it's hard to tell, is this hypokalemia or hyponatremia? But as a physical therapist, if you notice any of these kind of adverse signs and symptoms, and your patient is taking a diuretic, then this is worth reporting, worth getting in touch with the patient's primary care physician to discuss the fact that they could have a potential electrolyte abnormality, which can progress and lead to more severe issues. Again, we stated that hypotension, or low blood pressure, is one of the more common symptoms of all antihypertensives, especially the diuretics. So let's define what exactly is orthostatic hypotension. Orthostatic hypotension is when systolic blood pressure drops more than 20 millimeters of mercury, or diastolic blood pressure drops more than 10 millimeters of mercury within the first 3 minutes of moving from supine to standing. So again, this could occur in the first minute, it could occur in the first couple minutes, but within the first 3 minutes, it's this drop from supine to standing of more than 20 systolic or more than 10 diastolic. So the symptoms of orthostatic hypotension you're probably more familiar with. Most of us have had this at some point in our life when we kind of jump up from squatting down on the floor or jump up from a chair quickly. We get lightheaded or dizzy, swimmy-headed. We may even get blurred vision or a headache. Kind of ultimately, we may kind of stumble, fall, or have a syncopal episode where we pass out. Orthostatic hypotension is more prevalent in patients with diabetes and other autonomic nervous system disorders. And this is because patients with diabetes and autonomic nervous system disorders may not sense, just like patients with diabetes may have a peripheral neuropathy, they can also develop a central neuropathy where they're unable to sense that their blood pressure is dropping and therefore their body doesn't respond appropriately. So why is orthostatic hypotension so important? Well, it's correlated with falls and fractures and premature death. So thus, I think it's important for all patients, but especially patients taking antihypertensive medications, that we as physical therapists assess for the prevalence of orthostatic hypotension in our patients. And then either consult with the patient's primary care physician or provider, or caution the patient about how fast they move, about their symptoms, about drinking water kind of before they get up, taking it slow, doing some ankle pumps, not moving, so that we can help them better manage their orthostatic hypotension. In summary, hypertension and antihypertensives are quite prevalent in the population today. I think physical therapists should routinely monitor blood pressure in patients to screen for both hypertension that might be undiagnosed, as well as to assess for orthostatic hypotension in patients. We should be aware of the adverse effects that antihypertensive medications have on patients and monitor for those. And we should also assist patients with lifestyle modifications to help them better manage their blood pressure, as well as orthostatic hypotension.